Thanks, everyone. I appreciate people are still sitting down, but we need to keep moving, so I'm going to start this next session. First of all, I'd just like to remind everyone who's interested that there's an Airway Leeds lunchtime meeting today. You've probably, as Airway Leeds, all been emailed about this. It's in Hall 7. Sandeep Sudan's chairing that. Hall 7 at lunchtime, so grab some food and then head there, please. My name's Barry Maguire. I'm delighted to be chairing this session today. I have to start with a slight apology. This session is meant to have as a centrepiece a patient with the name of Jen Taylor, who unfortunately cannot be with us today, as I'll explain shortly. So I'm going to say a few words in her absence, and then the two main speakers are going to take over. Kate was going to chair with me, co-chair. She's now a speaker. So thanks for moving over, Kate. The session has been titled, What Should I Say and When Should I Say It? So it's really trying to take a patient perspective on conversations we may have with patients in relation to airway management. It was also titled A View from Both Sides at one stage, but let's stick to what we should say and when we should say it. I'll get started. So as I say, there's going to be two speakers to follow on from me. Kate's talk is going to be Let's Talk, and that's really from patient perspective, conversations we have. And then Professor Sandhu is going to speak about a lot of different things in relation to his practice as a head and neck surgeon, but he's also going to touch a bit on conversations and unexpected occurrences in airway management. This is Jen. Some of you will know Jen. She's a pretty incredible lady, and I only say that having spoken to her electronically many times. And she was supposed to be with us today. Jen runs a blog called The Cancer Chronicles, which you can look up. And I'm going to say some things from her blog in her absence. I think she was going to say some different things. It would have been much more entertaining than me, and it would be much more impactful as well, because one thing Jen is impactful if you read her blog. So second best is me reading this out if I can. So there we go. So Jen, I'm going to speak on her behalf. I am Jen Eve Taylor, and I have cancer. Always the overachiever, decided to go for a rare one, and not just once, not just twice, but 3 times. Osteosarcoma, diagnosed in 2017 of her jaw. I've had 7 months of grueling chemotherapy, 24 hours a day, 5 days a week, and then surgery in March 2018 to remove the tumour and reconstruct my jaw from bone from my shoulder. The roof of my mouth was made up of skin and muscle from my back. I went a year without any top teeth. After 2 years of being cancer-free, it came back. I had it removed again, along with my right eye, my cheekbone, dental implants, all the original reconstruction removed. And then it got into the base of my skull, and they think it's there to stay, incurable. Oh, the joys, but I'm still here though. And that's a reflection of the way Jen delivers banter on her blog in relation to her condition. And then a few weeks ago, she contacted the 3 of us on our WhatsApp group to say, I'm afraid I can't come to the DAS meeting. And this is what she put on her blog. On Wednesday, the 8th of November, the world went dark. And I'll let you read that. So Jen used Siri to contact her friend Rosa, telling her she couldn't see. Rosa said that she'd be on her way that minute. And at that time, Jen said, I packed a bag and tried to make myself a smoothie in the darkness. Rosa turned up an hour or 2 later with much needed coffee, and then cleaned up the mess of the smoothie attempt that had gone slightly awry. They got a taxi to A&E, where she had some blood tests, CT scan, to check she wasn't having a stroke. Various medical people popped in and generally agreed that it all looked fine. Typical of Jen, that's all well and good, she said. Do your routine test, but I need an MRI ASAP. This is probably cancer. She tells it straight, does Jen. But no one seemed to be listening to me. By 7 p.m, the A&E doctor said it won't be cancer because you've had a recent scan, looked all stable. But as Jen says, I'm wary of people who offer me absolutes. She's been through a lot, this lady. 8 p.m, they tell her there's no beds, the hospital's full, and 2 a.m, they eventually find her a bed in A&E, and she wonders what's going to happen next. There's loads and loads and loads on the blog of Jen. I picked out a couple of things. One was from 2021 in relation to pre-assessment, just that made me sort of giggle a bit. This is a patient's experience with interaction with what we do. The phone rings when I'm out walking. Hello, is that Jen? Yes. I'm here from the Head Neck Administration team, just calling you back about your pre-assessment. Calling to book your pre-assessment. My what? Your pre-assessment, before your surgery. Oh, I'm having surgery. Yes, on the 25th. Oh, first I've heard of it. Do you know what surgery I'm having? No, I don't know. Let's see if there's anything in your notes. That's the patient's perspective of pre-assessment. What about anaesthetics? I'll let you read this. It's nothing startling. And of course, we don't know what was said and what went on, and it's certainly no criticism on my part of any anaesthetic input. I'm sure some of my patients have said something similar. It's just to reflect on patients' experiences being different from ours. In this case, Jen says, I wouldn't have panicked and thought something was wrong if I'd been warned. Maybe she was warned. Who knows what was said to her? But that's her reflection. And that's what I want to consider a bit today. And she stresses in her blog lots of times that she thinks her anaesthetists are amazing. Finally, I know that Jen was going to talk about tracheostomy and her experience of tracheostomy today. That isn't on her blog, and so I'm not going to talk about it. But I think she isn't a fan of tracheostomy. And you'll hear a little bit more about tracheostomy later on from Prof. Sandhu. My reflection on Jen's blog from reading quite a lot of it, and Kate and I have talked about this quite a lot, is just a reminder of how things differ when you consider a patient's view and experience of anaesthesia and airway management compared to what we think as slightly blinkered sometimes anaesthetists, and particularly in relation to what we do with challenging airways. Finally, just before Kate comes on, I'm just going to mention DAS guidance document that we've been working on for several years, and it's taken too long. I've been the chair of that. We've done our best to do it to the best of our ability. It's soon to come out to be viewed. And one of the things that we consider amongst ethical clinical practice in airway management in relation to all sorts of things are the conversations we have with patients. And that might relate to information you give patients regarding their airway management, certainly in terms of obtaining informed consent. Material risk. I'm sure you've all heard of that terminology in relation to the Montgomery judgment. Materiality refers to what the lawyers would say is that what a reasonable person in that patient's position would likely attach significance to in terms of risk. That's quite difficult. Or what a doctor should be reasonably expected to refer to in relation to that particular patient's desires and preferences and knowledge. So material risk differs between patients. Do we all have the ability to, or the time, the ability, the scope to consider material risks in our patients? And what risks are they? Do we talk about death with all our patients in relation to airway management and anaesthesia? Shared decision-making, patient autonomy, some of those things you may think aren't really relevant to airway management. Surely we just tell our patient what's going to happen. I would argue that perhaps that's not always the case. And then any training we're going to deliver, any innovation, new devices, new techniques we're going to be using, should we be discussing that with our patients? So that's all for the future. I'm just touching on that just now because it's really relevant to what we're talking about today. When we ask patients in our group what they want to know about airway management, It varies hugely. Some want to know nothing, some want to know quite a lot. And that's the personal approach. Basically, patients seem to want to trust their anaesthetist to act in their best interest with regards to airway management. So, as long as we're behaving in a way that we would want to be behaved with us or our loved ones, it's probably reasonable. But certain patients want an awful lot more, and perhaps we need to explore that a little bit better. So Kate Rivet is the DAS representative, the DAS lay representative on the committee and has been for several years. She's a hugely experienced individual in quality assurance, providing expertise in relation to patient-public information, in application grants, in clinical trials applications. She's contributed to the guidelines, not only this ethics guidelines that we've been working on, but also the 2015 revision guidelines. And she's going to speak to you today quite simply on conversations that we might be having with our patients in relation to anesthesia and airway management. Her title today is just simply called Let's Talk. Kate.
Good morning. Firstly, I'd like to thank the organising committee for allowing me to present at this august scientific meeting, and for Barry for your kind introduction. I've been delighted to participate in this important session, and I echo the fact that it would have been considerably enhanced if Jen had been able to be with us, and we obviously wish her well. Barry and I have talked extensively about the best way to communicate with patients and what they might actually want to know in terms of airway management ever since we met over 3 years ago. We even had a brief discussion about the title for this session. I favoured Let's Talk over Let's Talk about Airway Management. I'm obviously not an anaesthetist, but I do have some thoughts about how the somewhat sensitive subject of airway management can be communicated to your patients. I think this helpful quote from a former chair of the college, what used to be called Patient Liaison Group, neatly summarises the lay role within a clinical environment. As the DAS lay representative, I'm well placed to witness the academic and research initiatives the DAS continue to undertake in improving patient safety and generating better patient outcomes. DAS is inclusive in recognising the importance of the lay voice, and as a result, I do participate in a number of projects, including the ongoing revisions to the 2015 intubation guidelines and the ethics guidelines, as Barry has mentioned. The aims of the ethics paper are to place a strong focus on how, when, and where best to communicate with patients in relation to airway management and anaesthesia, including discussions on risk and the manner in which this key topic can be addressed. Barry has already indicated some of the complex areas to do with materiality. The DAS ethics guidelines have been developed against the background of the Montgomery ruling, and by participating in this group, I needed to brush up on my understanding of this key Supreme Court decision. I found this statement very useful. The use of verified patient information is a helpful adjunct to any patient conversation. Good patient information can prove to be an effective starting point for many conversations and can also benefit the clinician. Well-informed patients are more likely to effectively prepare for that anaesthetic and subsequent surgery. I have previously made the point when speaking to other clinical groups that medical professionals would not be deemed to be upholding the tenets of the Montgomery ruling by merely advising their patients to look it up on the internet. The aim of any explanation to the patient is to provide them with the information they require to enable them to make an informed decision about the treatment proposed. The GMC, when referencing Montgomery, made this carefully considered statement. And I'm going to talk a little bit about what might be constituting a meaningful, clear conversation. Oops. There. That's what I think constitutes a meaningful, clear conversation. So incorporates patient-orientated language, a risk discussion with a supported graphic, and provision of appropriate verified patient information, either as text or as an infographic. So if we look at patient-orientated language, first as students, and then as you develop as doctors or other healthcare professionals, the use of medical language becomes increasingly common. This enables clear communication between other members of the clinical team, but conversely might hamper communication with your patient. Distal, proximal, lateral, anterior, simple examples of elite medical language. Some of the anesthetic terminology, laryngoscope, topicalization, intubation, would be equally unfamiliar to the majority of your patients. Considering Anne Murray's comments in the earlier slide, the lay advisor is there to draw on their relevant experience and knowledge to suggest how, as airway managers, you might consider the conversations you have with patients. The use of patient-orientated language can make the consultation, however brief, more effective. Most patients will be highly anxious when, as anaesthetists, you meet them. It really helps them if you are able to set out the key message in a clear and approachable manner. To do this, perhaps consider adapting the commonly used medical terminology and using more familiar phrases. We will be using local anaesthetic to numb the area is not patronizing, but is significantly clearer than our preferred method of topicalization. You are far less likely to oversimplify language to a knowledgeable patient than you are to overcomplicate to the totally uninitiated. Most patients will be seeking assurance that they will be safe throughout anesthesia, and whilst you have a duty to explain risk, the knowledge that you will be responsible for their care throughout the surgical procedure would prove to be reassuring. The concept of risk is not necessarily easy to explain in terms of airway management, but the explanation of risk is one of the key components of the Montgomery ruling. I'll just put this up briefly because Barry has actually already covered materiality. Prior to anesthesia, the patient is often invested in the surgical procedure. They may well be considering their recovery with their focus on a positive surgical outcome, rather than expecting to consider the risks associated with the necessary anesthetic. Many patients would also struggle intellectually with the mathematical concept of percentage and risk and how this might apply to them. The college have a very clear infographic which is available on their website. The Patient Information Resources section has a document entitled Anesthesia and Risk. This infographic from the Risk at a Glance section clearly explains the basics of risk in a format that would be accessible to most patients. The college has, however, recently updated their risk series, and Tim used some of the newer images in his presentation yesterday morning. By using familiar groups, this diagram clearly demonstrates the likelihood of something happening to you, which is, of course, what the patient needs to understand. By contrast, Adam Kay, in his latest book, Undoctored, described this rather more unorthodox approach to his day of surgery consultation. Looking at the provision of appropriate patient information as text or an infographic is helpful. The last time I was invited to speak to clinicians about the use of patient information, I delivered my introduction in French. This certainly gained the attention of the audience, but the point I wanted to make was the disconnect between using a specialist or elite language and the comprehension levels of a mixed audience. As airway managers, you will encounter the same issues with your mixed patient group. Some will have a basic understanding, and many will have gone multiple anesthetics. But there will be some that firstly do not understand, and secondly would rather not know. Whilst this is just a brief introduction, by immediately providing this written version, it might give some of the audience a few clues. By providing anybody who was interested with a hard copy, they would have had the opportunity to undertake their own translation. The practice of airway management may well be distinct from anesthesia in its general sense, but any anaesthetist does need to consider how they manage the airway in most anesthetic scenarios. While patients have not routinely been provided with complex details of anesthesia and airway management, the changing nature of clinical practice against the backdrop of the Montgomery ruling necessitates further consideration of the pre-anesthetic consultation. Another piece of advice from the GMC along this theme. Whilst considerable work is undertaken by DAS to perfect the theoretical concepts of quality care, I do observe that there are difficulties associated with translating these idealized patient care pathways into the practical within a challenging workplace. Earlier this year, I was invited in a lay capacity to visit and observe an anesthetic list to enable me to both engage with patients and witness modern-day anesthesia. The first early morning patient was booked for extensive head and neck surgery. They had made their way to the hospital that morning and was seen by the anaesthetist in the theatre suite about 7:30 in the morning. They were understandably on their own, and they were facing life-changing surgery. They were clearly anxious. The delightful anaesthetist calmly and clearly explained that for reasons of safety, the patient required an awake tracheal intubation. This was the first time that the patient had been made aware of this. In addition to all the other factors they were facing, they now had to comprehend another set of clinical terms, a different process, and this instantly and visibly increased their anxiety. Having then seen the surgical team, they were in the anaesthetic room within 20 minutes, still requesting that they would prefer a normal anaesthetic. They hadn't had time to fully understand the need for the alternative procedure, nor did they fully understand the reasons why it was necessary. The reality was stark. Had they perhaps had an opportunity to discuss the concept of ATI at an earlier appointment and be provided with a hard copy explanation of the process, they might have well been happier to comply and would certainly have had a chance to absorb the information in their own time. This double-sided DAS patient infographic for ATI is now routinely being used within the department. I understand that its effectiveness is being monitored in certain patient groups. The glossary on the reverse is key to the patient not only understanding the process, but also the language used by the anaesthetic team throughout their time in the anaesthetic room. There is also a long-form version with written information, which is available with this infographic on the DAS website in the patient section. This patient information has recently been revised and from today is available on both the DAS and the RCOA websites. Only page 1 and 2 are shown here. It is actually quite a long document. The Royal College of Anaesthetists has access to translated versions in multiple languages, although that hasn't been commissioned yet. The information covers anaesthesia and airway management in more general terms and does also have a link to the ATI infographic, which I just showed you. I would like to think that DAS will shortly be able to distill most of this document into an infographic to help those patients who struggle with the written word to understand the key concepts of their airway and breathing during anaesthesia. I have a realistic understanding of the pressures placed upon you all, particularly for day of surgery admissions. In such a limited time, it is not easy to gain all the important information you require prior to anaesthesia, make an assessment and devise a treatment plan. It is possible, perhaps, that adopting a wider MDT approach might improve the general level of communication of key facts to your patients. Greater engagement with the nursing members of the pre-assessment clinics could be useful and is possibly already established within your hospitals. Perhaps requesting that nursing staff use the DAS and RCOA patient resources as part of their assessment could be beneficial. The patients would then have a chance to consider some of the wider aspects of anaesthesia and actually be better prepared physically before surgery. The DAS RCOA literature makes reference to what can you do to be fitter for your surgery, including, for example, advice on routine dentistry care and the importance of fasting. Whilst patients might have a couple more questions for you on the day, they will be better placed to make informed decisions. Whilst the complex cases may well be referred to an anaesthetist clinic, most patients would benefit from greater clarity regarding their treatment options in relation to airway management and anaesthesia. It is widely acknowledged that communication with patients regarding risk is challenging and care should be taken when approaching this issue. The use of clear diagrams can aid these discussions and can also demonstrate to the clinician the level of patient understanding of the concepts raised. As airway managers and anaesthetists, you do, however, need to consider the Montgomery ruling and the concept of having a meaningful, clear conversation. Thank you very much.
Thanks, Kate. Brilliant. We'll have questions at the end if there's any time. Our next speaker is Professor Guri Sandhu. Guri is a consultant otolaryngologist and laryngologist in head and neck surgery at Charing Cross, the Royal Brompton. He's also Professor of Laryngology at Imperial College. He's lead of the National Centre for Airway Reconstruction at Charing Cross. He's a past president of the British Laryngological Association and the Royal Society of Medicine section on laryngology and rhinology. And he's extremely well published, 150 papers plus, more than 20 book chapters, textbooks, all sorts. Today he's going to speak to us, though, give us a presentation entitled Any Critical or Unexpected Steps. Thanks, Prof. Sandhu.
Good morning, and thank you for the organisers for this invite. This is where I work, and the bulk of my practice is laryngotracheal stenosis. So I spend my time trying to take trachees out, and I try very rarely to put trachees in unless it's part of a procedure. So when I was first invited to give a talk here, I was told to speak about how doctors damage airways. So I thought, fine, that's great, I can talk about that. And then subsequently I was asked to talk about consent for patients with unexpected tracheostomies or tracheostomies. And I felt that consent was not my strength, but I thought I could talk about how not to get into difficulty and let you know when we do consent for tracheostomy, and generally a little bit about my practice. I hope that will be helpful. So this was an unexpected tracheostomy, and Anil Patel may remember this case. So having done airway surgery for 25 plus years, before COVID, I had to do this twice. And I remember both cases, and they were both at the Throat, Nose and Ear Hospital. During COVID, we adopted a different technique of operating on the airway because of the risk of transmission, aerosol, etc. We were doing intermittent intubation in patients who were perhaps on the larger side. And we did this twice within 6 months. And my colleague and I, we thought, well, this isn't on. We can't be doing this because clearly it's not safe how we're doing it. And between us, even though we're both of an age and we're both of ethnic origins, high risk, COVID, etc., we decided we were going to go back to the practice we had before for the sake of the patient, and that's what we did. So we can all make a list of cases where we expect to put a tracheostomy in and consent appropriately and talk about tracheostomy, and we have a nurse specialist who will go and talk to the patients and tell them what it means to be breathing through the neck and how they should manage it and all the rest. And we can even introduce them to patients who have tracheostomies. We're also familiar with the sudden need to secure an airway. So pretty much the scenario as before, but at the top there you've got a situation where you're just thrown into, say, an arrest situation in the emergency department and you've got to do something. Sometimes it's a patient who's been niggling along, coming in and out through a head and neck clinic, radiotherapy changes, and suddenly they present with an airway obstruction. And then you have someone who gradually goes down. And in these acute situations, I say to people, get the best anaesthetist, get the best ENT person, and get them equipment in the right setting, and they're the two people who will establish a safe airway if it is possible. But there are situations where we don't expect to encounter problems, but they do happen. So even in routine anesthesia, and you're all familiar with the Elaine Bromley case where routine anesthesia and things went downhill. I mentioned NAP4 because it's the single most important document in my career that I have read. It has changed my practice. It just overnight, I changed my practice because what came out of it told me what was safe, what wasn't safe, and that's what we've done since. Now, situations where you perhaps don't expect to end up thinking about a tracheostomy, usually head and neck cases, and yes, thyroid goiters, large thyroid goiters, and I'll talk about why the problem might go downhill there. Surgery on the neck, especially if they've had a hemithyroid and you're doing the second side. That's another tricky situation where there can be a risk of an unexpected tracheostomy. Thyroglossal duct surgery, surprisingly in my career, I've had to go in urgently into the airway where the airway is obstructed, hematoma subsequent to that. Head and neck cancer, obviously, if they've done radical surgery. Second side carotid artery surgery, similar to second side thyroid surgery. The reason being they've probably partially damaged the nerve on the first occasion, and they properly damaged the nerve on the second occasion, and the patient wakes up with stridor, or doesn't wake up and has a tracheostomy and wakes up with a tracheostomy. And similarly, anterior approaches to the cervical spine. They put so much traction on the central compartment sometimes that both nerves can be temporarily knocked off. And the other situation where I've seen tracheostomies going in, and I've seen something similar in the last 6 months, is the management of airway stenosis, where perhaps the surgeon or the anesthetist is not their routine practice, but they're doing it. Similarly with tumors in the airway. Relapsing polychondritis, to me, is the most nightmare airway scenario, and I'll mention why that is the case shortly. So I don't need to teach you guys how you buy time. We still use Heliox. We still have helium-oxygen mixture. You can use the airways. Laryngeal mask, we do a lot of this, and we use it to bail situations. If I'm trying to get a laryngoscope in and I'm struggling, SATs are falling, the anesthetist will go back with a laryngeal mask. Thrive, Optiflow, I think this has really made unsafe situations safer. And we use it not in routine practice, but where we expect to get problems or expect to get into difficulty. And we'll have it running in parallel to jet ventilation sometimes. Various forms of surgical airways, intubation. The other thing that a lot of people don't think about is actually doing surgery to make the airway better. So if someone's got a tumor of the larynx, you could actually, in a specialist service, someone who has the skill set, debulk the tumor, and then they don't need a tracheostomy. As I say, this was revolutionary. It's another revolution in my career as an airway surgeon. But a word of warning about that. If it's running, oxygen is a heavy gas. The environment becomes inflammable. We all worry about airway fires. With this, you need to worry about fires in general. Garments, there's yours, bits of inflammable equipment, any ignition to an inflammable area, they go off in flames, so be careful about that one. So I'm just going to talk a little bit about my practice, because I was originally asked to talk about how we damage airways. 50% of the time, because you look at the first two causes at the top there, it is intubation. It's time spent on the intensive care unit. And then there's a whole set of conditions that we're probably familiar with that might damage the airway. So on the intensive care unit, what is going on that puts some people at risk of a stenosis? Sizing of tubes, cuff pressures, we've got quite good at this now, so those aren't really major risks in the Western world. Patient agitated, tube moving around, reflux, reasons why the patient is there, comorbidities, immune system. And something that people don't consider is that we all have different healing biologies. You don't have to be from the African continent to sort of keloid in your airway. And we've done some research that shows that fibroblasts in a given individual at different sites have different levels of aggressiveness in their behavior. And we've biopsied airway stenosis patients, and they have more aggressive fibroblasts. So generally, a lot of these people self-select. A minor injury becomes a big problem in those with aggressive fibroblasts. So bear that in mind. Tracheostomies. The incidence of airway stenosis with a tracheostomy and an endotracheal tube, in my experience, is roughly similar. It's where it happens. So this is just to highlight tube sizing. Your tracheal diameter tends to get larger if you're taller. It doesn't matter about your sex. So certainly at Imperial, we encourage our colleagues on the intensive care unit to think about putting a tracheostomy tube in if you've got to a week, week and a half, and the patient doesn't show any signs of being extubated soon. And for all of those reasons, but for me, if you leave an endotracheal, I said the incidence is about the same with trache versus endotracheal tube. If you damage the glottis, the workings of the vocal cords, that is always going to be a compromise of voice, airway, and swallowing. Whereas if you convert to tracheostomy, then you damage the trachea. That's a plumbing exercise. You can cut it out and join the ends together. So that's why I encourage early tracheostomy. And this is just to show you how good anesthesia on the intensive care unit has got. In 1968 paper, 20% of patients leaving the ITU had some kind of airway stenosis compromise. By 2005, it's got down to about 5%. And the main change here was the cuff design. And this is a large series. It's probably underestimating the incidence because they're only looking at patients that were readmitted rather than scoping every patient like the previous two papers. But it just shows you there's a trend towards less and less airway damage on the ITU. That was until we encountered this. And we saw a lot more airway stenosis cases. And the incidence, if you can read the numbers there, basically people's series, 22% subglottis, 17% glottis. I can barely see, there's 40%, 10%. And that's about 15%. So just show you that the incidence has gone up. So why were we seeing a lot more damage? Because this was a unique cohort of patients. It is very rare that we intubate patients on the intensive care unit in large numbers with a laryngopharyngitis when the tube goes in. They have inflammation here, and then you're putting a very large tube, or the largest you can, with a large person with comorbidities, and they need to be ventilated often for longer. Then you need to keep moving them with this tube, then that abrades the airway as you move them, and they tend, as I say, stay on the ITU a bit longer. So I feel, and a lot of my colleagues feel, that the incidence of airway stenosis was certainly higher as a result of COVID infections. But there are people who are looking at mass numbers and say overall the effect is actually marginal. But I'm not completely persuaded on that. I'm very lucky in that I have a big team. And most of our airway cases in tracheostomy patients, etc., are discussed and managed in a multidisciplinary setting. I've highlighted the MDT coordinator because without him, things just don't work. And we have psychology, and we have all sorts of people who can help these patients. So if someone's going to get a tracheostomy, they get, if they wish, they get to meet a person, they get to have a discussion with a nurse specialist, who will then manage the tracheostomy if they're local to us. So based on NAP4, I said I had changed some of my practices. Anil Patel very early on told me that inhalation anesthesia was a technique without evidence, and it was unsafe, and that was confirmed by NAP4 in my eyes. Awake fiber optics similarly. Transtracheal cannulae, we used to put a lot of these in, and I could never get it right. I put them in, all looks fine, then you start the surgery and it's kinked or something's gone wrong, and I thought, I don't want to let on, but I got a high failure rate with this. And it was nice that I had that validated. And what we tend to do with our airway compromised patients is they come into the anesthetic room, they get paralyzed, sometimes they spray the larynx, sometimes they don't. The LMA goes in, they're wheeled into theaters, and we put a laryngoscope in. And there's this varied pattern of disease. I know some colleagues would like to tube all of these patients, but in some of these situations you can't get a tube in without damaging the airway, and it just seems unnecessary, really, if a laryngeal mask will work. And we have shown, again, through Anil's practice, when we were working together, that flow volume loops actually improve once you have the patient paralyzed and you take over ventilation with a laryngeal mask. This is just to show how relaxed it can be in an all-day airway. When we do 15 cases of laryngotracheal stenosis in a day, sometimes an airway reconstruction at the end of it, there's no patient in the room when I've pictured these. It's just between cases. Outside of my immediate family, these are the people I trust most. And we work like one organism. And there's banter going on, but everyone knows what to do when something goes wrong. And there isn't a rotation of anaesthetists. I don't turn up on a day and it's not the anaesthetist I would expect for that day. These partnerships are very, very important. and I hope they have the same sort of trust in me. The theatre team, the core component of the theatre team, remains the same. It's no good. They started this practice of, oh, well, people have to rotate, they have to be multi-skilled. I said, no. If you want that, you take any risk and adverse event that comes into theatre today. And they backed off, and the core team remains the same. So I need to have people who know where the bits are when we need them in an emergency. And we have the same theatre each time, and all the ancillary equipment that we might need once every 2 years is there, because when you need it, it's important. And so it's always a designated same theatre. And if you're doing airway surgery, be dedicated to it and do lots of it. Don't be the occasional surgeon, and that counts for anesthesia as well. Don't be the occasional anesthetist who does complex airway surgery. So practice is patients go into the anesthetic room. Obviously we have a chat at the beginning of the day, and we highlight those that we might think may have problems. And they tend to just get paralyzed, laryngeal mask, they get wheeled in, and then we do suspension laryngoscopy. And in theaters, I pull the mask out and put the laryngoscope in. This is what it looks like. We don't put the suspension arm on the chest. If you're jetting, why would you put a suspension arm on the chest and tamponade it in a patient who already has an airway stenosis? And then the jetting is through a cannula attached to the laryngoscope. And it depends on which laryngoscope we're using. Most of the time we use the one on the left, which sits up against the cord, so you can do transtracheal jetting without much difficulty. The one on the right, when we're working above the cords, is the Lindholm. And because there's a distance involved from the cords, and there may be a bit of angulation, it's not laminar, we tend to put a Handsucker in or a subglottic jetting catheter, and that's probably where we use the Handsucker. You are all familiar with this approach to the larynx, because I've looked at the from the 1850s, I've looked at documents and how people came to realize the best position for doing a laryngoscopy. Sadly, a lot of my colleagues do not understand this very simple position. There have been various studies in the MRI, etc., showing that this is the way to get access to the larynx reliably. A lot of my colleagues will start dropping their head and doing all sorts of other things. Head up, head up, head up, head up, keeps going up. We use jet ventilation. We don't use the one on the left. I started off with a machine top right. Now we have the newer version of the machine on the top right. I like the machine on the bottom. A little bit noisy, but I do like it. You get jet and super added tidal volume. I try not to use laser tubes. I try not to put tubes in the airway. If you put something in the airway that can burn, chances are, if you do enough cases, it will burn. This idea that you have to reduce the oxygen you're jetting is complete rubbish. You will set a fire if you put something in the airway that burns and you ignite it. If you have no ignition, nothing will burn. If you have nothing flammable in the airway, nothing will burn. The patient is not going to spontaneously combust. And what do we do? Some of my colleagues believe that around the world, that you have to reduce the oxygen. I don't see why. But anyway, this is a stenosis. We put a bit of steroid. We make some cuts. We balloon it. It's done in 5 minutes. And the patient can breathe and they wake up. Now I'm going to talk about those cases where I think things can go wrong in my practice. So I mentioned second-side thyroidectomy, second-side carotid artery surgery. But the problem is that when you do the vocal cord check, someone puts a little flexiscope in, and it's usually a registrar, gets them to go sniff, and the cords move. And the cords twitch, and he says, both moving. I emphasize to the trainees, I don't want you to tell me they're both moving. I want you to tell me to what percentage of expected movement do they still have individually. Because if they've had surgery before, you may have a twitch on one side, but it's not abducting fully. The risk now is that if they're doing surgery on the side that's good, then potentially there could be problems when that patient wakes up. So you do an e-sniff, and I get them to document exactly what the level of movement is. So these are tumors in the airway. The middle one is thyroid surgery. On the left is just a stenosis. In the middle is a thyroid invasion. The one on the right is squamous cell cancer invading. We're using a microdivider. And this is all on jet ventilation. Obviously, you've got to make sure that and you have suction diathermy there if it bleeds. So what happens with large goiters? So this is a CT scan of a large goiter that's going to have surgery. And this is what the airway looks like endoscopically. And they said to me, should we stent the airway before? I said, no, just carry on. Tell the patient they might need a tracheostomy. So what is going on? Because people say, well, it's malaysic, isn't it? That's why the patient runs the risk of a tracheostomy. The problem is you're putting a tube into an airway that's compressed and now narrow. So you bruise it and going in, then you bruise it during the operation. And then the anesthetist is moving the trachea with the tube inside. You're causing more injury and more bruising. Big goiter. There may be a little bit of weakness of the nerve afterwards, which may recover. And hence, when you wake the patient up, they tend to need a tracheostomy. If you're worried about malacia, get the tube drawn out slightly and feel the trachea behind where the goiter was and feel if it is soft. Because I have never had a patient keep a long-term tracheostomy for so-called malacia from a goiter. So I don't think it is malacia. I think it's just a compressed airway that gets traumatized by a tube, a lot of movement, and then there's maybe a neuropraxia involved. This is malacia. Malacia being that the cartilage is soft. That bulging you get from the trachealis is not malacia. That's expiratory dynamic airway collapse. That is a separate entity that we do not completely understand. We don't even know if it's passive or active, but malacia is where the cartilage is soft. And you get this for various reasons, but the one that scares me most is relapsing polychondritis. If it's bad enough, you're going to have problems waking that patient up. And if you put a tracheostomy in, what you end up doing is you remove their end auto-PEEP. These patients learn to breathe in a manner where they keep resistance as they breathe out, and this keeps their airways open. As soon as you put a trachea in, you bypass that, and the patient is unable to maintain patency of their large airways. So whatever you do, you run into problems. So if you put them to sleep, try and wake up. That transition from being asleep to being awake and breathing is the challenging one. And I've lost a lot of years of my life just thinking, what do I do? Is this patient going to end up tubed? Is this patient going to end up with a long trachea? What's going to happen? So they are the most scary patients for me. Some examples of where things went badly wrong and I planned it wrong. This is a tumor below the thoracic inlet. And I thought it was an adenoid cystic or some odd cancer. So I said to my anesthetic colleague, I can have this out in 5 minutes. So we'll start jetting, and we're going to have problems jetting. The SATs will go down, but I will be out before you realize, and it'll be fine. Stupidly, BMI 72. So we can't get a tube in past this because we'll knock it off and cause bleeding. And the first thing I did when we started jetting was I put a little sucker on it just to see how it's pedunculated. It started hosing, got bleeding into the airway in a man of BMI 72, and I hadn't prepared adequately. And the only tube, we always have a size 5 microlaryngoscopy tube by my shoulder. Grabbed it, put it down, and packed above to tamponade the bleeding. Now we've got a 72 BMI with a size 5 microlaryngoscopy tube and a tumor. And you can't get a trachea in because it's below where you put the trachea in. So what I actually did in the end was I took a microdebrider that you saw earlier with a tumor, and I just cut it off parallel to the tube, and then I suctioned the base, and we managed to get that out, and the patient woke up, and we were fine. But that was bad planning. So back to the consent topic. We've seen that judgment from the High Court. And it's interesting, I was trained by one of my trainees at Grayson Road was Professor Tony Wright, who was also a master's in law. And he told me about consent. And he said, you tell them any common risks of what you're doing, but you also tell them about any serious risks or any significant risks, even though they might be rare, but the patient would upset the patient. And it's interesting, all these 30 years later, the ruling has sort of pretty much said the same thing. And the other thing you must mention as a surgeon is alternatives to what you are proposing, because you will lose a court case if you haven't mentioned alternatives. So you must also mention that. What do I consent patients for, all these airway stenosis patients? The most likely problem that I might cause for the patient is chipping or loosening a tooth. That is always mentioned. Obviously bruising, numbness, Tracheostomy only in cases where I know that the problem is difficult, like a relapsing polychondritis case, like a tumor case, or if we're doing an airway reconstruction, they will end up with a tracheostomy. 15,000 tracheostomies percutaneously, 5,000 surgical. Many don't keep them, but having a tracheostomy changes your life big time. So a patient is going to get seriously pissed off, excuse the language, if they wake up with a tracheostomy. Interestingly, people who live with tracheostomies can make very clever camouflage and disguises to their tracheostomy tubes and carry on. But what it means is your life changes overnight. You can't do anything without prior consideration. You need help, you need hospital visits, you might have to stop working. There are all sorts of implications, which means that people do not like tracheostomies. So it is important, if you think it's going to happen, to consent appropriately. I just wanted to say I'm a big fan of percutaneous tracheostomies. I do them in preference to surgical tracheostomies unless a junior wants to learn. If you're putting a tracheostomy in and you don't want to get problems with displacement, especially with this increasing obesity crisis, stitch the tube close to the lumen, not out there, because it'll just flex out and sit in the neck and you'll have problems ventilating. And I tend to use ribbons. I don't like lyofoam because it takes a centimeter of the trache tube's place in the lumen. It pulls it out ever so slightly, especially if they flex the neck. I like the, sorry, I'm lasering someone. I like the flat trache dressings. And lastly, I realize there are some training practical courses here on front of neck access, and I think this is an important skill to have. And the scalpel bougie wholeheartedly agree. And I don't know if this is taught. So I took 2 of my trainees the other day, laid them down and took pictures. Chap on the left, laryngeal prominence. No problem working from there, finding the cricothyroid membrane. Look at the young lady. The most prominent thing she has when you feel is the cricoid. And I've had trainees doing airway surgery where they've thought the cricoid is the laryngeal prominence in a woman, because the larynx can sit flat and be actually recessed. And the young ladies in the room, please have a feel, and you might realize in your own neck that that is the case. And they start with a cricoid and they work down and they end up putting a tracheostomy in. Fair enough, but it's not what we're teaching them. And I say to people, the most reliable landmark in your neck is your hyoid bone. Now, it doesn't matter how obese the patient is, you will feel the hyoid bone. It feels different, it's flat, it's bony, then you work down and figure your gaps out. And if you do that, you will not go wrong with the anatomy, and you won't get into trouble. Thank you.
Thanks, Guri. That was incredible. I'm aware of the time. We were forced to start late. I suspect the request from the organisers is for me not to have any questions. Yes, I'm getting the sign. So I really apologise for that, because I'm sure there's lots of things people want to ask. Guri, Kate, Kate's not going to be around. You've got to go, Kate. Guri, are you around for the next hour or so?
I'll hang outside. Excellent.
If anyone wants to ask Professor Sandhu a question, please grab him after this next speaker. But apologies for no time for questions. Thanks very much to our 2 speakers for excellent presentations.
Good afternoon. This is a very exciting time. We have our keynote address now, and I have the honour to introduce him. Dr. Richard Harris is his name, but I think he's known as Harry Harris. And I think very few people in the room haven't heard of Dr. Harris. He's an anaesthetist in Adelaide, and he also works in the aeromedical medicine unit in Adelaide. But his passion is cave diving, and that was his kind of hobby. But I think they both converged when he was doing a thyroid case, I think, when he got a phone call from the divers who were involved in the rescue in Northern Thailand of 12 young boys and their instructor, so 13 people. So I think his life probably changed after that, and we're looking forward to hearing about it in that. I think many of us have seen the rescue, which is online, and it's a phenomenal watch, and it's done very well and great footage, so I would recommend you all watch that if you haven't. He's also written a book called The Art of Risk, and I do think he's a risk taker, and I'm sure you will hear all about it when he talks to us about his topic, which is anesthesia in the dark. All of us, I think, watching, if we've watched The Rescue, got tachycardias when we were watching it, and it was a phenomenal achievement. He's been honoured by the Association of Anaesthetists. He got the PASC Award, which is their award for courage and for anaesthetists involved in this sort of courageous acts. And also, he was voted Australian Person of the Year in 2019, and many other awards, deservedly so. So we are honoured and delighted that he has come to this meeting here in Birmingham, and he's going to talk to us about anaesthesia in the dark. Thank you very much.
Well, thank you very much for inviting me, Sajay, and the faculty. It's an absolute honour to be here. I'm a great fan of DAS and all the work that's been done by them over many years, and certainly has informed our practice and made our patients much more safe whilst we practice anaesthesia. I would disagree with one point, that I'm certainly not a risk taker. I'm sure I'm much like all of you. I'm a good risk manager, in my opinion, and that's certainly what I explained to my wife when she says, "Why are you going cave diving again?" Because like all things, like anaesthesia, cave diving is one of those pastimes which should be 99% boredom and pleasure, and only 1% terror. And I feel like my training as an anaesthetist and my training as a cave diver have really got a great synergy and a lot of overlap. I've entitled my talk Anaesthesia in the Dark, but in keeping with the theme of this conference, I think it actually would have been better called How to Make 13 Perfect and Easy Airways into 13 Very Difficult Ones by submerging them underwater and in an opaque environment and turning the lights out. So, I mean, these boys were perfect anaesthetic specimens, and it was only what we proposed to do to them that made their airways potentially difficult. It's nice to be back here in Birmingham, because in 1991 I actually started my anaesthetic practice as an SHO in Warwick, doing anaesthesia and intensive care there. And so it's very nice to come back to this part of the world. And I was reflecting last night on, all those years ago when I started out, and I went to the ODP stream this morning. As someone mentioned, that used to be ODAs, but back when I was here, and think about the times that those ladies and gentlemen saved not only my career, but my patients' lives. I'm sure as many of you would have had that experience as young anaesthetists starting out in such a busy system like the NHS. But around 1991, I'd already been diving in the ocean for about 12 years and had already been cave diving for about 6 years. So in many ways, this rescue in Thailand seemed to have my name on it. It seemed to be part of fulfilling my destiny almost. I felt that I was going to be involved or become involved in something that could use those two different skill sets that I'd been working so hard on to develop. Now, I've only got 30 minutes to tell a story that took over a couple of weeks, so I better crack on with the account itself. And apologies to those of you who probably know this story better than I do now from watching all the TV shows and reading the books and getting the T-shirt. But hopefully I can give you a different personal perspective as to what you might have seen in the news or by watching those accounts. So it is over 5 years ago now that these 12 boys from the Mupa, or the Wild Boars soccer team, finished their training on a Saturday morning at the local soccer club, and along with their 25-year-old coach, they decided to go off to the Tamlawan cave for a bit of an adventure. Now, I think when you're a young boy in a remote and rural part of northern Thailand, and you're surrounded by this fantastic jungle and mountains and this most excellent cave, that's exactly what you should be doing as a young lad or laddess. And on this occasion, they went back to the cave. And they'd actually been in there many times before. In fact, it had become a bit of a ritual for the team. On this occasion, it was one of the boys' 15th birthday parties, but they often took new teammates in there for a bit of an initiation. And it was a perfect day. The sun was shining. There was no sign of rain. There's a sign out the front of the cave that says from July till November is the cave flooding season. So they were inside the safe period of time. But every single year, the monsoon does arrive sometime in July or August, and that cave will very predictably flood. And in fact, you can see in this photo that was taken on the evening that the boys failed to return from the cave still looks dry. But within about 48 hours, there'll be a very powerful river flowing out of the entrance to that cave. Now, just to put you on the map, we're in the very most northern part of Thailand, right up against the border of Myanmar, obviously formerly Burma. And these boys lived in a bit of a transient community. They're actually mostly from Myanmar. They were from a minority tribe called the Shan people, and their parents travelled back and forth across a fairly open border and traded in the market by and large in that little village of Mae Sai. And so the reason to tell you that is that these boys had a pretty tough upbringing. I don't think they'd ever lacked a roof over their heads or food on the table, but life was quite hard for them. They were very poor people. And actually, I think that resilience that was born through those years of a little bit of hardship would stand them in very good stead when it comes time to what they're about to face inside this cave. Now, if you jump in a car and travel to the south down to that yellow pin, that is the entrance to the Tamlawan cave, and it's only about 10 minutes in a car. These boys rode their bikes down there. And from the pin, you travel into the west, and I'll show you a map of the cave shortly, but you travel into the west underneath that cloud to a part of the cave where there's a T-junction. It's about 1.6 kilometres into the cave, and at that point the cave branches to the north and south. So I'll just show you that map now. So the bicycle there obviously showing the entrance to the cave, and 1.6 k's into the T-junction. And if you stand at that T-junction and you look to the north, that part of the cave, the very skinny bit called the Monk Series, is a very uninviting bit of cave. It's a sort of a muddy tube, and you were to go up there, as some cavers have obviously done because they've created this map, but you'd have to crawl and winkle up into this pretty uninviting bit of cave. But if you turn left and go south, the tunnel is much more open and easy walking passage. And so we were pretty confident that's the way that the boys would have gone. And in fact, when they had gone in there before, this cave, which has 10 kilometres of tunnels in it, they would go about 5 kilometres to the south from the entrance, where they had a bit of a special chamber, almost like their club room that they would go to. And they would usually write their initials in the mud and then turn around and come back out. And that's what they did on this occasion. And they just got back to the T-junction. And it's at that point that they realised that the cave passageway in front of them was flooded with water. And that's because that's actually the lowest part of the entire cave. And what they hadn't realised was that when they went in, it was already raining over the other side of the mountain range, and the earth was becoming more and more sodden until suddenly the water had come up through the ground and had started to flood that part of the cave. And then second to that, the water had started flowing down that Monk Series and was pouring into the T-junction itself. So over the next couple of days, the cave, as I mentioned, did completely flood. A river started to appear out of the entrance, and the blue parts of the cave on this map now show the parts of the cave that would actually require scuba diving to pass through, a total of about 1 kilometre of cave passage that required diving. And in between those bits there would be like a river flowing through the cave between ankle deep and over your head in depth. So quite a significant obstacle. Now, when the cave started flooding, the boys were obviously, trapped and worried, and the first night they just slept on this sandy beach there. The next morning they awoke to find water lapping at their feet as the water started to rise. And they spent that next couple of days before it flooded completely, just walking up and down that southern passage between the red circle and the T-junction, looking for another exit or looking for a way to escape. And on day 3, they were around about where the red circle is, and they suddenly felt some wind and a bit of a noise coming down the tunnel, and they looked up to see a tidal wave or a flash flood coming around the corner. And it was heading towards them, and they were very lucky that they were standing right at the base of the only bit of high ground in the entire cave. And when you stand at the bottom in that red circle and you look up, there's a very steep, muddy slope that goes up about 10 or 12 metres, and at the top of that is a flat, muddy platform where they could all sit together. So when they saw the water, they all sprinted up this hill. The water rushed past literally as the coach was following them up, and they sat at the top of this hill, an area probably between me and that desk in size, all huddled together. They were just wearing their t-shirt and shorts from the training, no shoes or socks. They were already wet from being in the damp cave. These boys are all very fit, skinny little kids between 11 and 16 years of age, and their weights range between about 30 and 60 kilos. And they had no food with them whatsoever, so they basically sat there over the next, or total of 9 days, until they were found by those British cavers. So you can imagine how desperate that must have been for those little boys, thinking that no one knew where they were, because they actually hadn't told their parents where they were going that day. It's probably the only mistake they made, in my opinion. And they had no food, so they were increasingly hungry and increasingly cold. The temperature in the cave was about 23 degrees Celsius, so not cold, but remember they were wet and starving, so they did start to suffer from mild hypothermia as they sat there. And you can well imagine that their morale would have just started to plummet when they realised that now not only does no one know where they are, but also the cave is flooded, and even if their location was known, how could anyone possibly come in to rescue them? So I suspect they realised they were almost certainly going to die at that point. Now, in the early hours of that first Sunday morning when they were missing, the police, the emergency services all appeared on site, and it was realised that they need someone who was expert in their knowledge of the cave, and they called a British guy called Vern Unsworth, who was from Yorkshire originally, but now living in that part of Thailand because of the profusion of caves in the area. And Vern had contributed to the mapping of this cave, so he knew it very well. And he went into the cave at about 2 a.m, and he went as far as the T-junction, and he could see the water pouring in through this hole in the wall, the entrance to the Monk series, and he described it as just a really chaotic scene, a big whirlpool forming, deafeningly loud noise from the water. And he realised in that moment that if these boys had any chance of survival, if they hadn't in fact been killed in that initial flooding event, then they might need some cave divers to come over and help search for them. And being British, he knew of the British cave diving community, and he put out the call via the governor of Chiang Rai province, who contacted the British embassy, who contacted, through the British Cave Rescue Commission or Council, these two guys. And in our fairly minority sport of cave diving, and I'm not really sure why it's not a little bit more popular, but there don't seem to be a lot of people, keen to participate. But in our small global community, these two guys are really the rock stars of our sport, and I'm very, proud to be friends of these guys, particularly the guy on the left, Rick Stanton, and his longtime dive buddy, John Valanthan. Now, Rick was a firefighter just over the road in Coventry, and I'd been on a couple of expeditions previously with Rick, so I knew him quite well, and I certainly knew of John and many of the other British cave divers. It's a very popular sport, in fact, in Britain, and a lot of the legends of the sport and a lot of the history of cave diving comes from this country. So you're certainly batting above your weight, I suppose, in that particular sport. Unfortunately, also in rugby and some other places, but... Anyway, so Rick and John arrived on scene, and when I heard that they were there, and I'd been following this event for quite a long time, really from when the boys went missing. Rick and John arrived on that Wednesday, so about 5 days after the kids went missing, And they immediately got their gear on, went down to the entrance of the cave, and they faced two obstacles. And the first one wasn't the cave itself, but actually it came in the form of the captain of the Thai Navy SEAL Regiment, who was pretty much standing guard at the entrance to the cave. And when he saw these two old blokes rock up in their homemade wetsuits and equipment, cave divers are very proud of our innovative MacGyver sort of approach to problem solving. And these guys are kind of the best of that in that regard. So when you see Rick in his ensemble of homemade diving equipment, it's pretty, it's not awe-inspiring, let's put it that way. So, you know, compared to the spit and polish of the Thai Navy SEAL Regiment, you can imagine that they looked singularly unimpressive. And the captain was pretty blunt in his criticism of them. And Rick and John, very good cave divers, but perhaps not the best diplomats in the world. So a bit of a stoush ensued, and in the end the captain said, look, if you silly old blokes want to go and kill yourself in the cave, that's entirely up to you, but we're taking no responsibility. So Rick and John went off into the cave, and very shortly after reappeared with their tail between their legs because of the force of the water that was coming out of the cave. It was really impossible to dive in there. But to their credit, they went back and tried again the next day, same result. But then on the Friday, something seemed to have changed, and probably a combination of two things. The rains had eased off, and secondly, that the water pumping operations that were in place started to take hold, and they found that they could make their way forwards into the cave. Now, when you're cave diving in water like this, I mean, remember that the annual monsoon essentially at the moment is flushing out a year's worth of mud and grot out of the cave. So it was basically like swimming through iced coffee or chocolate milk. You couldn't see your hand in front of your face. And when I'm diving in water like that, I tend to close my eyes. It's just less confronting than staring at the darkness. There's no point turning a light on of any kind. And so they would have been feeling their way forwards, you know, just pulling themselves hand over hand through some very tightly restricted parts of the cave. And of course, always dragging a bag full of climbing rope behind them and tying that off every 20 or 30 metres so that they could always find their way back out of the cave. You know, that's sort of rule 101. If you're thinking about taking up cave diving, that's the first lesson. Always have a piece of string to find your way home. And so incredibly difficult and courageous bit of diving. And between them and the Navy SEALs and some other European cave divers that were on site, but you know, the lion's share of the work done by these two guys, finally on day 9 they surfaced in chamber 9, and you probably recall that incredible bit of footage from John Valanthen's GoPro camera when they see these kids, these very skinny ghostly figures coming down 9 days after they've been missing, coming down this hill, and John calls out, "How many of you are there?" And one of the boys, Adul, who speaks a little bit of English, says 13, and John goes, "Brilliant." And at that point, I think this is when the story became a global phenomenon. That footage actually came out of the cave via a fibre optic link from Chamber 3 that the SEALs had set up. That footage came out of the cave before John and Rick got out of the cave. So when they got outside and everyone was applauding and cheering, and of course the parents of the kids there were just crying with joy, Rick and John thought something else must have happened, and they didn't realise that the news was already out of the cave. But those of us sort of in the know were thinking when we heard this news, well, actually that's probably less than half of this problem solved, because how do you get 13 boys who we were told at the time couldn't even swim, how do you get them 2.4 kilometres out of a cave, which was going to require diving through some extremely difficult and technical countryside underwater there? So I'd been talking to Rick via WhatsApp, and as was mentioned, I was in the operating theatre. It's interesting to hear that talk about thyroids, because I've never been a believer in tracheomalacia myself, and so I was doing my regular thyroid list that morning and exchanging a few sneaky texts with Rick Stanton. Normally when I give this talk to a group of bankers or accountants and they hear that, what do you mean you're doing texting while you're patient? I say, well, don't worry, half the anaesthetists I know are doing the crossword or you know, looking at their stock market or something. At least I was working for good. And so Rick and I continued to message that morning, and then he rang me at the end of my list, and basically he was asking 3 days after these kids had been found, he was saying there's no possible way the kids are coming out alive. He wanted to leave Thailand because he didn't want to stick around just to do the body recoveries. And then he came up with this outrageous idea. He said, is sedation possible so that we could sedate the kids to stop them panicking while we dive them out of the cave? And you know, I don't think you have to be an anaesthetist and you don't have to be a cave diver to realise that a 3-hour underwater journey whilst you're unconscious is not going to end well. So I just said, no, that is impossible. I did know about Edgar Pask and his, you know, when he invented the Bain circuit, and he was anaesthetised and intubated and put in the swimming pool at the Royal Physiological Laboratories. Edgar's always been one of my heroes, which was why it was so gratifying to receive that award. You know, that was the only case I knew of the combination of immersion and anaesthesia, and yet I was being asked to consider, you know, this unprecedented technique to try and rescue these boys. So I was very clear on the phone. I said, no, it's absolutely impossible. You know, I had in my mind 3 very major concerns, and I had about another 100 sort of other concerns. But the 3 major concerns were that obviously if you're going to render someone unconscious with an anaesthetic, and you know, lay people use the word sedation, but obviously I knew there's no sedating these boys. They have to be unconscious if they're going to be brought out without panicking. Even if we use a